I'm Stephanie. I am a registered nurse. I work as a clinical application specialist with Cheetah Medical. And today what I want to do for you is walk you through the setup of the Starling non-invasive cardiac output monitor. We want to talk a little bit about the hemodynamic profile. We also want to talk about how to perform a dynamic assessment. So we want to look at how to do a passive leg raise. We want to look at how to do a fluid bolus. We're going to look at trending stroke volume as well. So that's all going to be really exciting. Before we jump into all of that, what I really want to do is talk about why we care, right? We want to talk about why do we care about volume management. Let's start with the why. Ever since the beginning of IV therapy, clinicians have been asking themselves whether or not additional fluid is going to help their patient. So will my patient improve perfusion in response to fluid? This is a really crucial question. So is my patient fluid responsive is really the question we've been asking ourselves. So blood pressure was one of the earliest tools for measuring perfusion, and of course it's still in use today. We still use pressure today. The ability to clinically measure central venous pressure came next, and that was developed in the 1950s. We had the development of the Swan-Ganz catheter in the 1970s, allowing clinicians to invasively measure left heart pressures, essentially. More recently, though, we have actually learned the limitations of pressure-based measurements. They're static, right? They're not really predictive of fluid responsiveness, which is important to know. In the 1980s, we have the echo that came on the scene, right? And that was readily available, allowing clinicians to visualize ventricular volumes. But unfortunately, what we also know is that volume alone is also not a good indicator of fluid responsiveness, essentially, right? So only recently have clinicians been able to determine to have the ability to assess whether or not the left ventricle will increase cardiac output in response to a bolus of fluid, with giving a patient additional fluid. In the early 2000s, a lot of work was done using respiratory-based loading of the heart to assess fluid responsiveness, right? So we have our pulse pressure variation, we have our stroke volume variation, often utilizing pulse contour technologies. Those rely on changes in the respiratory cycle to load the heart, all right? So it requires a respiratory cycle to load the heart. This actually works very well, right? But it's very difficult to implement in clinical practice because it requires our patient to be intubated. They have to have a stable rhythm. They need to be, paralyzed, and that makes it really difficult to implement on our patients. So more recently, where we are today is we have the Cheetah. We have an ability to non-invasively determine that direct measurement of your stroke volume index, and we've eliminated the need to use those respiratory-based techniques. So today, again, either using a passive leg raise or a bolus with the Cheetah non-invasive cardiac output monitor, we can see what is the heart doing with the volume that we just gave this patient. So assessing fluid status and fluid responsiveness is an age-old problem, right? So other than a new technology, what is new? Today, through large population-based studies, we have retrospective research, we have health services research, and we're learning how important better fluid management really is for our patients, all right? So conceptually, we've known that we have increased complications with either giving our patients too little volume or not enough volume. So you're going to see on your screen now, you're going to see the Bellamy curve, and what we see on this Bellamy curve is that if I give my patient too much fluid, or if I give them not enough fluid, essentially I'm causing the same complications in my patient. What we see there is that every single patient has an individualized volume need. They have an optimal volume place for them, for that individual person. And what we need to sort of unpack here is the two areas where this literature is very, very strong. So in enhanced recovery after surgery and in sepsis. So in enhanced recovery after surgery, they've convincingly demonstrated that tighter fluid management is important for our surgical patients. We have fewer complications on either side of that curve. And then, of course, in sepsis management, we have, Dr. Rivers, we have the PROMISE process and ARISE trials that demonstrated many years ago that aggressive early resuscitation saved lives. We also know now that volume overload leads to increased mortality in septic patients. So the point is that we really want to get fluid right for each individual patient. That's really important. Over the past 10 to 15 years, we have been gaining insight into basic physiology, right? So it was actually only with the advent of dynamic measures in the past 10 to 15 years that we have been able to directly assess that left ventricle's response to fluid. What is striking is that when we do assess these patients, only approximately 50% of hemodynamically unstable patients are going to increase their cardiac output in response to a bolus of fluid. So in other words, only half are benefiting from that fluid. Study after study has shown this. Represented here on your screen, you have the 2002 meta-analysis. We have a 2016 updated meta-analysis by Monet that continues to confirm these results, right? So, since fluid overload is a significant and highly morbid problem, many leading clinicians are now adopting the use of dynamic measures to guide their fluid therapy. This is being done the world over, right? So the use of dynamic measures are being endorsed by ISACHEM, by NICE, the Surviving Sepsis Campaign, the National Quality Forum. You've got SCCM. So in fact, in our new updated 2016 Surviving Sepsis Campaign guidelines, they have also included the use of dynamic measures. So this is really crucial conversation here, right? So now that we know that it's important to use dynamic measures, how do we do that, right? How do we assess a patient's individual Frank-Starling mechanism? So there are three ways to directly assess a patient's individual Frank-Starling mechanism. We can do a passive leg raise, we can do a fluid bolus, or we can trend their stroke volume. So let's unpack those three things. A passive leg raise is a non-invasive fluid challenge that uses the patient's own fluid volume to directly challenge the heart with volume and measure its response, right? We're really measuring the heart's response to the fluid. After gathering baseline data, while the patient sits semi-recumbent, we actually lay the patient back and we elevate their legs to 45 degrees. This maneuver translocates approximately 250 to 300 cc's of the patient's own blood to their heart, and we measure the percentage change in their stroke volume. And by looking at that, we can determine if the patient is likely to increase their cardiac output in response to further fluid. In other words, they're fluid responsive. That's what we mean. The same direct challenge can be accomplished by actually giving a 250 or 500 cc IV bolus. So if you're going to give 250 cc's, you're going to get that in your patient in 5 minutes or less. And if you're going to give 500, you have to get it in your patient in 10 minutes or less. Additionally, you can trend stroke volume over time as you're administering your fluids. So a stroke volume essentially that's increasing during fluid therapy shows a positive response, right? A stroke volume that's flat or decreasing really should raise questions for you about the value of further fluid for that patient. So how do we actually use this information in taking care of our patients, right? Really the same way that we always have. So it helps with the decisions that you are already making. Of course, it starts with, do I have a pressure problem? Do I have a blood pressure problem? Do I have a perfusion problem? I'm going to be looking at my map, and I'm going to be looking at my other, clinical signs, technically. And then we're also thinking, is my patient unstable, or are they becoming unstable? So actually, trending stroke volume may be helpful here because my stroke volume will change before my blood pressure changes. So we know that the body is always compensating, right? It's working to maintain our blood pressure, right? And if the body is struggling with perfusion, then you may see a drop in stroke volume before you actually see a drop in your blood pressure. So that's really helpful for you to know. So do I have a pressure problem? If the answer is no, we're done. right? If the answer is yes, then usually our next question is, well, do I need fluid? Will fluid work to help correct this perfusion problem, right? So we can now determine the answer to that question by performing a passive leg raise or a fluid bolus, right? If fluid alone will not correct your perfusion problem, then there are two more crucial questions that we want to ask, perfusion questions that we want to ask of our patient, right? Does my patient need a vasopressor? Or a vasodilator potentially, but does my patient need a pressor? So I'm going to teach you how to look at your patient's vascular tone on the monitor, which is going to be super fun. And then the last one is, does my patient have enough contractility in their heart? In other words, we're going to look at whether or not they would need potentially some inotropic support to help them with their squeeze. And when we look at the hemodynamic profile on the monitor, we're going to walk you through this step by step by step so that we lay it all out for you nice and easy. What I want to do is we want to stop right here and we want to recap with what we know. So what we know is that giving too much fluid or not enough fluid is not good, right? It's problematic for our patients, so we know that. We know that volume overload in septic patients leads to increased mortality. We know that approximately 50% of hemodynamically unstable patients are not fluid responsive. In other words, they are not going to increase their cardiac output in response to getting a bolus of fluid, so that's really important. And we also know that essentially we have three core interventions that we can do for our patients to help maximize their perfusion. We can give them volume, we can give them a vasopressor, sometimes a vasodilator, or we can give them inotropic support, right? Because 50% of hemodynamically unstable patients are not fluid responsive, then we need to check to see if they're fluid responsive before we actually give them volume, before we give them fluid. So we're going to actually move into that discussion now and talk about how to set up the monitor from start to finish. All right, so let's talk about proper sensor placement. So essentially what we want to do is we want to box in the heart. We want to build a box around the heart with the sensors. So you need two sensors above the heart, above the aortic arch, and you need two sensors below the heart. So let's start with the upper sensors. You'll notice on the sensors actually you can see a picture of the frontal view telling you where to place the sensor on the patient's thorax. Remember, we need to keep all four sensors on the actual torso of the patient, okay? So upper sensors can straddle the clavicle. They can straddle the trapezius, or you can march that sensor around and you can put it on the back of the patient. So sensors can go on the front or the sensors can go on the back. So a couple of things here. The white tabs always need to point to the patient's toes. So you need to keep the sensor nice and vertical, even if you go on the back. So that's one thing for the upper sensors and the lower sensors. Also, if you have a pacemaker, you need to be roughly 3 inches away from an AICD or a pacemaker. So we recommend in that case to just put that particular sensor maybe on the back. They can go on the front or the back in any combination. So if I have one on the front, there can be 3 on the back. It doesn't really matter. As long as I have 2 sensors above the heart and 2 sensors below the heart, I'm actually okay. So we, again, with the upper sensors, we can straddle the clavicle, straddle the trapezius, or we can put the sensor on the upper back. For the lower sensors, those typically go at the level of the umbilicus, right? So that is where we would want to place the sensor on the lower part of the patient. You do need good skin prep. So clean, dry, intact skin, that's what we're looking for. There is a little emery board that comes in the pack with the sensor, so you can lightly abrade your patient's skin before you apply the sensor. They're good for 48 hours. They can go to CT, they can go to X-ray, they cannot go to MRI. You can place a tegaderm over the sensor if that will help you preserve the life of your sensor a little bit longer. Okay, so that's really good. Let's also talk a little bit about abdominal breathing. So when your patient particularly is really tachypnic and they're breathing really fast, you actually can just place all 4 sensors on the back if that's causing a lot of artifact in your patient. Feel free to go ahead and do that. We do that a lot sometimes in the emergency department. So in summary, here we are. We have 2 sensors above the heart. We have 2 sensors below the heart. We have good, clean, dry, intact skin. And then we go ahead and we plug the sensors into the cable, the patient cable, red to red, black to black, and then we can go ahead and we can hit start. Okay, so we want to press and hold the power button to turn the monitor on. Please remember that the power button turns it on only. Okay, it doesn't shut it down. So when you're ready to actually shut the monitor down, you'll exit to the main menu, and in the main menu you will physically click the shutdown button and it will verify that you want to shut the monitor down. So we're just going to wait for this to boot up and then we'll go ahead and select new patient. All right, so we want to go ahead and click new patient, and we're going to enter a patient identifier. I'm going to make something up because we are just testing. I'm going to hit enter or next, and then we're actually going to enter our patient's real demographic information. So the age of our patient is 32. The weight of our patient in pounds, you can change pounds or kilos. We're going to hit enter. The height of our patient in inches, again, you could be inches or centimeters. And then we'll genderize the patient, right? And so she is female, and we'll click finish. And if there were anything wrong here, we could go ahead and hit update, and it would take us back to the beginning and we could update our details. But we want to verify on this screen that everything's correct, and then we're going to hit start session. Notice the sensors are blinking red on the torso. So that's telling us that we need to connect the sensors. So the sensors will plug into the patient cable. The red jack goes to the red cable and the black jack goes to the black cable. We'll click those in and notice on the monitor that the sensors have now turned green. So red means stop, green means go. It's very intuitive. We're going to go ahead and hit start session now. The monitor will automatically calibrate upon initiation. The calibration takes 2 minutes. Please remember, calibration is not getting a baseline. Okay, I'm going to repeat that. Calibration is not getting a baseline. After calibration is complete, the white and red bar at the top of the screen will disappear. Calibration needs to take place once per shift or anytime new sensors are applied. You do have the ability to toggle through 5 separate displays by swiping the touch screen up or down. So I'm going to demonstrate that for you here. This is the full hemodynamic profile. We're going to come back to that screen. Our dynamic assessments screen, our minute-to-minute screen, and we have a trending screen here. You can get back to your screens, or go through them rather, just by swiping up or down. I'm going to go ahead and keep us in our full hemodynamic profile screen. Once calibration is complete, we can now perform a dynamic assessment by doing a passive leg raise, a PLR, or a fluid bolus challenge to determine if our patient is volume responsive. But before we talk about how to perform a PLR, I'm going to show you how to enter a map. We need to enter a map in order to see our patient's vascular tone. So this matters because we need to see if our patient has enough vascular tone to circulate fluid or if they potentially need a vasopressor. So what we would do is we would wait until the end of the monitor calibration process. You'll notice the banner is still in place. So we'll wait until the monitor is fully calibrated, and then we'll go ahead and we'll enter a map. Okay, so we're going to enter a map again in order to see our patient's vascular tone. So you're going to click in either the TPR or TPRI box, which stands for Total Peripheral Resistance or Total Peripheral Resistance Index, and then you're going to touch Enter Map, and then you enter your patient's map from your monitor. So we're going to just enter a normal map of 70. You can hit Enter or you can hit Next, and we will now have a full hemodynamic profile as soon as those boxes populate. So to keep it simple, I think of it like this. So back to the hemodynamic profile. Again, the stroke volume index is my preload lever, and before I pull the preload lever, I'm going to perform a dynamic assessment to determine if my patient is fluid responsive. In other words, will fluid be effective at increasing perfusion, right, or not? What's a normal heart rate, you guys? 60 to 100 beats per minute. Guess what? Normal stroke volume is also 60 to 100. And roughly half of that is your normal stroke volume index, 33 to 47. So as a reminder, I'll get a baseline stroke volume index for 3 minutes, then I'll challenge the heart with fluid, and if the stroke volume index climbs by 10% or greater, my patient is considered fluid responsive, which means they are likely to increase their cardiac output in response to a bolus of fluid. If my patient's SVI does not climb by 10% or greater, my patient is not considered fluid responsive. They are unlikely to increase their cardiac output in response to a bolus of fluid, and I can look at my other 2 levers to see if I can pull one or both of them to improve perfusion. The next lever is the afterload lever. The values that correspond with afterload are my total peripheral resistance and my total peripheral resistance index. Normal TPR is 800 to 1200. Normal TPRI is 1970 to 2390. I already entered my map by clicking inside the TPR or TPRI box and manually entered the map, so I'm able to see if my numbers are within normal limits or not. The lower the numbers, the lower my resistance. The higher my numbers, the higher my resistance. If I want to add resistance, I give a vasopressor. If I want to decrease resistance, I either reduce my vasopressor or I give a vasodilator. The third lever is the contractility lever. This is the cardiac index and the cardiac output. Normal cardiac output is 4 to 8, and normal cardiac index is 2.5 to 4. It is helpful to remember that a cardiac index of 2.2 or less is considered cardiogenic shock. If I want to increase or decrease my patient's heart contractility, I give either a positive or negative inotrope. If I'm concerned about my cardiac function, I can also get an echo, a 12-lead, cardiac enzymes, etc. In other words, I could do a full cardiac workup. So there you have it. Preload, afterload, and contractility, volume, pressors, and inotropes. Let's move on now and talk about how to actually perform a dynamic assessment. Okay, so we're going to select dynamic assessments, and then we're going to select PLR. And I'm going to go ahead and read to you what the wizard is telling you to do. So PLR baseline. Before initiating a PLR dynamic assessment, please verify the following. The pillows are removed from under the legs and the foot of the bed is flat. The sequential compression devices, your SCDs, are removed. And the patient is placed in a semi-recumbent position, which is how we have our Annie here. We're going to go ahead and hit next since we're properly positioned. PLR baseline, we will now establish a stable SVI baseline. Please keep your patient still and wait until the end of the baseline phase, which is 3 minutes. We're going to go ahead and hit next. So it's just warning you that we have a 3-minute baseline, right? So the baseline stage lasts for 3 minutes, right? There's a baseline timer right here in our protocol box, and it will count down for you. The patient should be semi-recumbent for this whole 3 minutes, all right? So we're going to keep them still, no talking. Remember, you guys, that a PLR has an excellent sensitivity and specificity, okay? We're talking 90th percentile, so that means that it's in the appropriate candidate is absolutely an excellent marker for determining if a patient is fluid responsive or not. In other words, will they increase their cardiac output in response to a bolus of fluid, all right? So we're going to actually stop right here while Annie finishes her baseline, and we're going to recap what we've done so far. We put 4 sensors on Annie's torso, okay? We turned the monitor on, we entered her MRN, her age, weight, height, and gender, and we pressed start. We let the monitor auto-calibrate, which we now know is different than getting a baseline, and then we initiated performing a dynamic assessment, which we are doing now. Okay, so after the PLR baseline is complete, there's a pop-up that tells us it's time to put the patient supine and elevate their legs to 45 degrees. So we're going to position the patient first, and then we're going to come back and we're going to select next. So now we're going to go ahead and hit next. And you'll notice that we have a timer that's counting down for us in our actual protocol box. So it says PLR challenge stage ends in 2 minutes and 51 seconds. So we will go ahead and we will wait for 3 minutes for the PLR to complete. So remember, what we're looking for here is a greater than or equal to 10% change in Annie's stroke volume index to be able to determine if she's considered volume responsive or not. All right, so now that dynamic assessment is completed successfully, we're going to go ahead and click OK and be able to view our results. We can sit Annie up now. Remember, if a patient's SVI percent change is 10% or greater, the patient is considered fluid responsive. If a patient's SVI percent change is less than 10%, the patient is not considered to be fluid responsive. Annie's delta SVI is 49.1%. So please note here, you guys, being fluid responsive does not mean the patient needs fluid, right? That is a perfusion question. So this report will highlight the change in stroke volume and cardiac output from the beginning of the PLR challenge and also indicate where the patient resides on the Frank-Starling curve. Okay, so before we talk about how to do a bolus challenge, let's talk about some of the things that can give us a potential false negative when we're doing a passive leg raise. So this could be very benign, like we forgot to turn off our SCDs potentially, or it could be something like our patient has increased abdominal pressure. So really anything that's going to impede that quick flow of blood from her calves back up to her heart could potentially cause a false negative result. So in those cases, it would really just be better if you went ahead and performed a bolus dynamic assessment instead of doing a passive leg raise. Okay, so we always wait in between dynamic assessments for our patient to return to their baseline. So notice Annie's SVI has returned to her baseline, so now it would be appropriate to initiate another dynamic assessment. So let's talk about how to perform a bolus dynamic assessment. We have two options. We can give 250 or 500 cc's. If I give 250 cc's, that has to get in my patient in 5 minutes or less. If I give 500 cc's, that has to get in my patient in 10 minutes or less, which means 999 on my pump isn't actually fast enough. I need to go ahead and put that fluid on a pressure bag. Please remember that you don't actually have to stop any other maintenance fluids or your antibiotics or anything else while you're going to be performing the bolus dynamic assessment. It's okay to let those things continue to run. Another way that you can actually do a bolus is just to administer it with a large syringe. So let's say that we have a 500 cc bag of fluid on a pressure bag with the line appropriately primed and hooked up to Annie. So what we would want to do is select dynamic assessment and then select bolus from the pop-up menu. The pop-up screen is instructing us that our bolus baseline stage will begin. So baseline, we will now establish a stable SVI baseline. Please keep your patient still and wait until the end of the baseline phase, which is 3 minutes. So we are going to hit next. The bolus baseline stage lasts for 3 minutes, and you'll notice the 3-minute countdown timer shown in the protocol portion of this dashboard screen. We're not giving fluid during this baseline stage, okay? Your patient can be in any position for the bolus dynamic assessment for both the baseline and when you're giving the bolus actively. Now, when this 3-minute baseline is completed, the pop-up screen is going to pop up and instruct us to start the bolus injection. So we're going to wait for the baseline to be completed. So when the 3-minute baseline is completed, this pop-up screen instructs the user to start the bolus injection. So we're going to select next after we begin our bolus. So pretend that I just started the bolus, and now I'm going to hit next. In the protocol box, this timer is actually counting up during the bolus injection because it's timing you. Remember, we're giving a 250 milliliter bolus in 5 minutes or less, or a 500 milliliter bolus in 10 minutes or less. Once the bolus is complete, we will wait for 1 more minute to allow the fluid to circulate. So this is really important. All right, you guys, so once the bolus is complete, again, we waited for 1 more minute to allow that fluid to circulate. So now we're at minute 3. We're going to select dynamic assessments, and we're going to end the bolus on the monitor. Dynamic assessment was completed successfully, and we're going to click OK. So just remember, again, waiting 1 minute after the bolus injection before ending the protocol ensures the peak stroke volume is captured in the equation for fluid responsiveness. So the protocol was complete. We selected OK. Our results are displayed in the protocol box on the dashboard screen right here. We're going to go ahead and swipe up, and we're going to see our bolus dynamic assessment. So again, after the protocol is complete, we can swipe up on the touch screen, and a larger and easier to see protocol is displayed. Again, this report highlights where the patient resides on the Frank-Starling curve, as well as the delta percent in stroke volume, which is important for assessing fluid responsiveness of the patient. Now that we have more than one dynamic assessment, we can swipe left to right to get older to newer data. All the Starling curves will save, and that's amazing, so I can go back earlier and see my previous dynamic assessments.
Hi, my name's Annie. I'm a nurse. I work as a clinical application specialist for Cheetah Medical. Now that we've gone through with you how to do the 2 different types of dynamic assessments, I'm going to talk a little bit about the types of patients that make good Cheetah patients. So let's talk about shock patients, okay? What do we see in all of our shock patients, okay? Hypotension, right? So any type of shock patient, whether it's sepsis or septic shock, hypovolemic shock, cardiogenic shock, neurogenic shock, these are all going to be good Cheetah patients, okay? If I have a CHF patient, I'm always going to be asking myself about their fluid status. Are they fluid responsive? That's a good Cheetah patient. And for that same reason, all our kidney patients, acute kidney injuries, and our ARDS patients are going to be good Cheetah patients as well. In addition, if my hospital has protocols in place that include hemodynamic monitoring, such as ERAS or perioperative goal-directed fluid therapy, if I have sepsis and septic shock bundles in place, if I have trauma protocols, if my patient meets those criteria, those are all going to be good Cheetah patients as well. So really, anytime I'm asking myself the question, is fluid going to fix my patient's problem, or I'm considering a fluid bolus for my patient, the information I'm going to get about fluid responsiveness from the Cheetah monitor may be really helpful. So let's talk about the classic patient we see all the time in the ICU. That patient on low-dose pressors that we just can't seem to wean off, okay? That's a great Cheetah patient. If I have a patient on an inotrope, say dobutamine, just as an example, that's going to be a great Cheetah patient as well. What about that patient I have that's received a lot of blood or blood products? Okay, so what happens when we give our patient banked blood? Well, banked blood, we know, is washed in citrate. Okay, citrate binds with calcium in my patient's system and actually decreases the heart's contractility. So in this case, that's why we build the administration of calcium into massive transfusion protocols, because in that case we're using it as an inotrope, even though it's not something that we traditionally think of as an inotrope. Okay? So remember that we said earlier we can trend our patient's hemodynamic information on the monitor. So I can put my patient on the monitor, I can titrate pressors and inotropes to effect, and I can also trend their hemodynamic numbers as I'm giving them any of these medications, fluids, or blood. And the best part about it, I don't even need an arterial line because it's 100% non-invasive. If you do have any questions, be sure to contact your local clinical applications specialist. Go to our website, it's www.cheetah-medical.com, or you can download our Cheetah Medical mobile app. It's in the Google Play or the iTunes Store, and you can have access to key Cheetah reference information at the bedside on demand.